one as well. I just wanted to talk to you about something for a couple of minutes before we get into this discussion. And before I even mention anything at all, can I ask the moderator, how much time do we have for our discussion? Open question and answer.
I mean, your presentation and discussion will be about 1 hour.
Great. So I just wanted to get an idea. So because I know we're going to be talking about some exciting things throughout the days to come, we will be going through many of the things in detail, but I just wanted to bring some pertinent issues here at hand. Okay, so I'm going to share screen just for one moment, and I'm going to ask you what you think about this. Can you give me the privilege of sharing screen, sir?
Yes, already sorted.
Thank you so much. All right, let's see if I can show you this. All right, so you see here a graph, correct? And Dr. Graham, do you mind giving me feedback so that I can, whenever I ask questions like that, you can tell me if, you know, if everything's okay, yeah?
Yes, all good, all good.
Yeah, very good. So you see here something very interesting, and it's not different from the UK or other countries. The leading comorbidities, a fancy word, right? Comorbidity, morbidity means illness, sicknesses. And so sicknesses that people have along with having COVID-19, because that's the illness right now that's taking over the whole world. So I'm showing you this, the leading comorbidities, which means that people who have died of COVID, but they have other illnesses along with that. And this is just in New York. I looked at the one in the UK and one in Japan, same story. There's no difference. The one in Australia, different numbers, but the same percentages. What do you see that's striking here? Hypertension and diabetes. That's really something, isn't it? And we don't know much as yet about why is it that hypertension and diabetes, we seem to have some notion, and we seem to feel that this illness, this infectious process has decided to enter the human body through a receptor, almost like the doorknob and the lock. And it seems to get in through there, but that lock that allows the virus to get in the cell is used by other systems, and most importantly, a system that handles our blood pressure. And so the receptor for this illness, infectious process, the SARS-CoV-2, that virus enters through a receptor called ACE2. And this receptor deals with our ability to moderate our blood pressure and also other things, but most importantly, blood pressure. So especially on blood vessels and in the stomach area, intestines, we find that there's lots of these receptors there. There's also a lot of receptors in the placenta. Very interesting. Isn't that something? But what have we found? We've found that people with hypertension seem to have a lot of illness. People with diabetes seem to have a lot of illness. And most people with diabetes, very rarely a diabetic doesn't have a blood pressure problem. Most diabetics have a hypertensive problem. But pregnant women, so far, we don't seem to see having so much disease burden. We don't see lots of women dying, pregnant women dying of. However, if you check their placenta, they have a lot of receptors for this specific door lock that allows the virus to get inside. Interesting. Now, children are not getting ill that much. They get sick, but not that sick. But as they get older, 16, 17, well, I should say 14 and upwards, that's when you start getting sicker. Or if their weight starts going up, they get sick. So I mentioned a few things here, but let me just throw another, as we would say, a monkey in the wrench. Then we start seeing people of certain minority groups having a far more extensive amount of disease compared to those who don't have, those who are other races, I should say. And so you look at this slide here, and you see here, can anyone tell me which group they see has the most disease?
Afro-Americans.
Yeah, so we're talking about Afro-Americans because they're in America. We could call them Afro-Caribbean if they're in England, and the Hispanics and the whites. I actually used this slide for, you may see in some Spanish words there, because I gave a presentation to some doctors in Latin America. But what do we see? We see this big line that goes all the way up, disproportionate. Imagine this, that less than 18% of the population of the US are Black. And you're seeing that more than 70% of the people who are dying of COVID, more than 70% of them are Black. So that's interesting. I'm just throwing some things out there. Now, when you go to Africa, now this is our same brothers and sisters now in Africa and the UK, take those same people now. We come from the same genetic line as our brothers and sisters on mainland Africa. You go over there, and there's not that this disproportion of death over there. So I'm teasing you now. I'm teasing you because I want you to talk to me, and we need to discuss this because this is real. And is there anything that we can do, or is it that we're genetically bent so that we have more ACE receptors or locks that allow the virus in, or is it that we have a type of polymorphism of our locks to our cells that allows it to come in easier? Well, if that be the case, why isn't it happening in Africa? Or is there something environmental in Africa that seems to be helping them? Do they have more sunlight? Some people may say they may have more vitamin D. Well, there's studies going on right now looking at whether or not vitamin D supplements, I think actually in England there's a study going on as well, to see vitamin D supplement as well as other supplements and see if they will stand alone, if that is protective or not. Interesting. But I just wanted to mention a few things there, but the ones that I wanted to look at was the morbidity and the death rate in people with certain types of illnesses, certain types of races and continents. Interesting. There's lots of possible theories. We don't know if they're plausible or not, but we see that there may be some elements of, for example, with women, we see that with women who are pregnant, there are two types of ACE existence. The ACE receptor, which is really the lock on the door that allows the virus to get inside. And sometimes it's in the liquid form. We call that the soluble form. And sometimes it's in the structural form, like my phone versus the liquid form, solid form versus a liquid form. And it seems to be that with the pregnant women, they seem to have more liquid form or soluble form of the virus. Sorry, not the virus, of the receptor, the ACE receptor. And so when we look at the fact that we're looking to see how much receptors pregnant women, they have a lot of it, but it's not the solid form that allows the virus in. Whereas on adults, they seem to have, especially those who are older, as they get older, they have less soluble form and more solid form. So that gets into a little more technical. There's one thinking, there's one form of thinking. And then some people are looking at, are we genetically engineered in such a way that our ACE receptors, that same lock on our doors to our cells, may be a little different in people of African, Caribbean, African American. But that seems to not play out on epidemiological levels when you look at large swaths of people in California, for example. You have people in Arizona who are indigenous American Indians that are getting lots of disease as well. And so, but however, they have the largest percentage of diabetes per population. That's another thing as well. And so I've mentioned a couple of things. Now, why not babies, little babies? That's interesting. Why are the little babies getting sick? I mean, we always talk about little babies being so defenseless and having a very low immune system, but show me the millions of babies that have passed away or gotten sick. You have very, very, very few babies that get sick from it. And so we look at the mothers to see, are the mothers giving the babies something? Yes, they do give them some things. They do give them some antibodies a little bit, something in the breast milk. They do pass on some elements, but that doesn't seem to be totally what it is. Some people have even looked at something really beautiful that I have been looking at as well, and that is a mother has a wonderful system in which she helps to not destroy her baby while her baby is in her womb, and her baby has a system to block mother from trying to destroy her. So you have this tug of war going on, mommy trying to keep a baby in her tummy that's foreign to her. Imagine if you have a piece of metal or a piece of glass in your finger. It's going to have chronic inflammation. You're going to have a war of immune cells. And what you're going to have is a rejection of that foreign body. But in a pregnant woman, praise be to God, that mother very, very, very rarely rejects that child, and that product dies. But the baby at the same time has an immune system that seems to back off to some degree. And that backing off seems to happen even when the baby is outside of the womb. Now, what does that mean? That means that there's a type of immune response, we call it Th1, Th2, fancy terms, that really does not aggressively respond to certain viruses. And remember that one of the problems that we have with the SARS virus, SARS-CoV-2 virus, is that the over response of the immune system, which we call the cascade of inflammation, chemokines, that seems to be causing much of the problem, partially. Yeah. And babies seem to have less response than respond. And so we see how God has made us in such a way, and these wonderful creatures, us babies, that seems to be able to not overreact, and then the mother at the same time not going into overdrive. And so she has some degree of control of her immune system as well. And so I just wanted to bring a few pointers to you and open the floor, and we'll discuss this. Remember, I don't have all the answers. Maybe someone sitting down there, God has given them divine wisdom to elucidate this, but I want to not leave this kind of thinking in the hands of the so-called scientists. I believe that amongst us, we can discuss these things, and God can open our eyes and he can show us things. Do you know that there was a time where Adam could, with his naked eye, look up into the universe and see stars and see the craters on the moon, and he didn't need a telescope? There was a time where probably before the antediluvian world where they could literally look down on an organism and see the cell without using an electron microscope. So I know that we're nowhere near creation, but I can tell you one thing: God has still left his spirit in us, and I believe that together we can know things that God has for us. And so I want to open the floor to talk with you and see if anyone has any pointers before we go into discussion about this.
All right. How we do it is that if you have a point, maybe at least to make it orderly, you can raise your hand, and I'll direct Dr. Graham to you. Or if you want at the present moment to have a burning question, you can go ahead with the question, but we prefer you raise your hands, and then we can look at you and acknowledge you. Any questions, guys?
Questions or thoughts? We want to hear it.
All right, my question is, Dr. Graham, you showed us a slide saying that Blacks and ethnic minorities are more prone to contracting and probably dying from COVID-19. What are your thoughts on this? Generally, people are saying it could be because of poor healthcare. It could be the fact that we that live in first world countries struggle with things like vitamin D and probably vitamin C. What are your thoughts on that question?
Yeah, well, in the infectious disease community, sir, what specialty are you?
Emergency medicine.
Emergency medicine.
Okay.
I pray for your soul, my brother, because you're on the front line. Let me just mention something. You know, there are people, I'm sure you folks have your screening, but we have people that will come in and literally won't tell us the whole information and will have symptoms. A lady, while I was talking to her about her baby was sick. And I said to her, has anyone had COVID in the family or any symptoms, etc.? Oh, no, we're okay, okay. And then I think the Holy Spirit said to me, ask her something specific. I said, how's your eating coming along? You eating well? And she goes, well, you know, lately I haven't been tasting the food that well. So,
wow.
And she's standing right in front of me, you know. And then I went into further questions. And so these are the things that we face, but that's an aside. Let me get back to the point. So in the infectious disease world and epidemiology, there's a lot of tug of war on that. And I think we're going to get some good discussion here because, number one, yes, look at England, UK, I'm sorry for England, United Kingdom, from the old days, England. Look at the United Kingdom. You see, if you look at the map, you see concentration before COVID of people in certain socioeconomic standings concentrated in certain areas. We may not want to accept this, but you don't live where you live because you have decided to live there. You may think you do, and I don't want to make anyone feel small about it. But when people came to the UK, and even in the United States, we have maps, and you guys have it as well, where we can tell how long you live based on your zip code. We know how long you're going to live, generally speaking, by where you live. We know how much money you make based on where you live. You know, we know the kind of cars you drive by the way you live. We know the type of insurance you have by where you live. When people came to the UK from all over the world as immigrants, they were placed in certain parts of the country. And as a natural progression of migration goes, whenever families follow families, or even families give birth to families, they still radiate in the same areas. And so Birmingham, London, and you can go on, etc., you will find the deep concentration of immigrants, three, four generations, probably 3 generations in those areas. You will also find the socioeconomic standing of those immigrants will be the lowest. And so that speaks then, and I will speak about that throughout our discussions. Health, there are very many factors that I mentioned this morning in the conversation we had this morning about the determinants of health and your socioeconomic standing, your understanding of your health literacy, and all these things, and just barriers to health. And so you have communities where people don't necessarily speak language, they don't have access to information. They're in situations where lots of families, 4 families are living in a place. 4 generations are living, and that's also cultural. And so I could go on and on and on about that. You have adoptive cases where you have multiple children from different families, and you've got different age groups. And so these kind of settings are a cesspool for an infectious spread of any form. That is not the setting for people who are of different socioeconomic standing or who are spread out in the land in a wider sense, geographically. And so in the US and in England, where people are sparsed out in villages where they have 2 acres of land around them, you don't find the same degree of contagion. Whereas when you live in a flat and you have to go down in an elevator, and you've got 3 generations living in your home, you're going to infect everybody in that home. And so that's one of the reasons here. Now, that's just one of the reasons why that's a heavy element in the association. We don't want to put causes yet, but a heavy association with minorities. And I think that's why the graph pronounces specifically African Americans, because I'm going to give you where the biggest statistics come from Chicago. All right, in Chicago, you got about 30–40% of the population being Black, but 70% of them are dying of COVID. And when you look at the death in the white population, you're talking about 25%. I can give you those same figures for England. And it's comparable, it's not as extreme as Chicago, because Chicago is just one city. But that's the same situation in, why is it that our colleagues in Dr. Graham's specialty, when you look at the face, the beautiful face of those healthcare workers, physicians and other healthcare workers that have died in the last 9 months, especially the physicians, look at their faces. They're all people of color. And it talks about also where are their jobs concentrated. And that's an important thing. Are their jobs concentrated in the city area? Are they in the inner city areas? And in the inner city areas, who are the people on the front line? And if you go out to other areas, which are more suburban, if they use that terminology in the UK, you're going to find that the majority of people on the front line are not of that color, and also where they live and how sparsed out they are is very, very different. The other thing is we seem to have a higher percentage of people, or the prevalence, I should say, of chronic diseases amongst people of color. So when you look at hypertension and diabetes, show me the numbers. We seem to be dying, we are dying of hypertension and diabetes and coronary heart disease 3 times the rate in the UK compared to whites. And is that genetic? A lot of it has to do with socioeconomics as well, and education and access to care. That's just a few things. Any other thoughts? Because I could talk forever about that. What do you think about that, Dr. Graham? Any thoughts on that?
From my perspective, I tend to believe that a lot has to do with our availability of healthcare, not necessarily in the UK, but in the US for sure. And because, as you said earlier, in African countries, the Caribbean.
I'm in now. I'm in.
Yeah, somebody's in. In African countries and Caribbean countries, the proportionate of Black people is completely different to other places. So I'm still the jury's still out for me on what was the reason for that. But in the UK, most of the Blacks were, as you said, were in the front line, but they were mostly security guards and people who do the cleaning, that kind of stuff. And the doctors a lot of doctors who died, they all had underlying conditions. And mostly doctors like ENT specialists who were people coughing in their faces before they even knew exactly how it was being spread and what were the symptoms, especially what you mentioned earlier about the loss of taste, because that only became a major symptom about 2-3 months after the pandemic started, and people were being exposed to those patients even without even knowing that they were COVID positive. So for me, the jury is still out why we as Black and ethnic minorities are disproportionately affected by COVID.
Thank you. Any other thoughts there? Well, let me just add to that we are very much aware that you will 10 to 12 times more likely die of COVID if you have hypertension uncontrolled and diabetes uncontrolled. And so that in itself drives this illness.
No, they shouldn't have no consult, so we're not going to do that.
Okay, see ya.
Okay, bye. Thanks.
Can I just ask everyone to be muted, please? Sorry about that.
Yeah. Oh, sorry about that. Yeah, I did want to say thank you very much, Pastor. I did want to say that 10 to 12 times people who have uncontrolled hypertension or chronic hypertension and people who have diabetes, they will die of COVID 10 to 12 times more likely. And that's a very serious figure. And I mean, within the last 7 months, we've been going over those figures over and over again, and it's a real issue. And there's biological plausibility to it as we understand how the virus enters the cell. And these people are rigged for the virus to just walk in with no care of no cures whatsoever and enter the cells and break its havoc. So that's important within itself. All right. So in saying that, we need to look at how our health literacy as well. You have people, especially people who are the majority of people seem to be, when you ask them the question, do you believe this virus is real or not? And certainly you get people who are educated above their first degree that may say maybe a hoax, etc. But the higher percentage of people who will say that this is probably not real or it's made somewhere else or it's brought on by some conspiracy theory, they're going to have lower education, high school or barely above high school. And so that has a lot to do with health literacy and understanding the illness and how the infectious process goes. And so we have families that live together and generations of families. And I want to ask you folks in England, how's that playing out? Because from what I know, especially in the inner city areas, we have lots of generations of families that live together.
There's a question on the floor. I think before you answer that one, Genevieve Mobir has a question.
Good.
Hello, hello, Dr. Graham. I had a quick question about, you spoke about women who are pregnant and them having the soluble receptor and the solid receptor. So what exactly makes women produce the soluble receptor, and is it just in pregnant women that they have this soluble receptor, or can anyone have it, and how do you know that you have it?
Yeah, well, every human being, thank you, Genevieve, for that question. Great question. We all have the receptors in its two forms, in its soluble form and its solid form. And so be that as it is, in different parts of the body, it's represented at different levels. So for example, in your nares, in your throat, in your trachea, and down in your lungs, you have the majority of receptors in that system, even though it's much more in the cardiovascular system where your blood vessels are, et cetera, et cetera, et cetera. So we all have it, and we all have it to some degree soluble and some degree, and it fluctuates between being a soluble and a solid form. It so happens that pregnant women seem to have the more percentage leaning towards the soluble form. And this is just a theory. This is not known, but it's a theory as to why they may not be affected as much. Because if you study pregnant women when they give birth and we take the placenta, we put it under the microscope, you see a whole lot of receptors, and they're infected. People who are infected, women who are infected, you check their placenta, and their placenta is not loaded with the virus, and they're not sick. They have, the only reason why they got positive is because you tested them before they got to the hospital, got into the hospital, because you want to make sure they don't contaminate everyone in the hospital, so they're asymptomatic. And so you look at their placenta, and the placenta is not full of virus. That's interesting, but they do have a lot of, well, if you test them for the soluble form, you find a lot of the receptors there. So that's interesting. So this is all we're just discovering this stuff. Yes, any other thoughts?
One more question. My wife just asked me, what do you think about vitamin D in the prevention of COVID-19? Yeah,
it's a good question. So vitamin D in of itself is really a wonderful vitamin. God gave us that vitamin. You don't find vitamin D in the shop, so please don't be going out buying vitamins all over the place, okay? I mean, it's okay to do that if you're lacking it, but if you can get sunlight, daylight, and especially a good 20, 30 minutes of it, when you have good daylight sunlight, it depends on where you live. Sometimes it's 10 to 11 o'clock in the day, or 3 to 4 in the afternoon. Depends on what kind of geographics you have. That's the better way to get vitamin D, because then it gets into your skin, and your skin converts it, and in your kidney, it makes it into a wonderful product that can then enter your your cells and begin to communicate. It's a drug, it's a molecule that helps us in communicating, especially when it comes to the immune cells. And so that's why it's very, very important. And we believe, based on Sister Graham's question, we believe that vitamin D has a major role. One of its role is in its ability to communicate and help with the movement of immune cells, especially the T cells, which helps us to either fight certain kind of viral illnesses. And so it's a possibility. I think maybe my thoughts are, it's going to be based on more epidemiological studies, meaning that you look at people who live in countries where there's lots of vitamin D, black race people, and you look at people in England who get very little sunlight and see if there's a difference, or you give the group of people in England a placebo, plus you give them vitamin D, and you never give another group nothing, plus vitamin D or plus placebo. You can do different combinations of things. But my hunch would be that I think it's going to be crucial. I don't think it's by itself, because I don't believe in solitary micro or neutral micronutrients. I believe that we're a holistic body, and so by taking zinc alone is not going to help you. By taking vitamin D alone is not going to help you, because in one of the talks I'm going to give, we're going to look at sleep, and you can literally see. I'll give you a little heads up on it. People who have chronic sleep problem, okay, which means that for many years they've been having problems with sleep. We have seen that their T cells, which specifically, we call them NK cells, that fight specific viral infections where the cell inside is infected, those people have reduced killing activity of those cells because of chronic sleep. So because sleep has to do with a lot of hormones that help to stimulate the production of lots of other cells. And one of those cells are the cells that help us with our immune function. And we see that people who recoup their sleep and begin to sleep well, we see an improved activity of those killer cells. So even sleep itself can decide how much killing your cells does to a virus. That's just one element. That's why we cannot be very singular in our thought. We have to be very comprehensive. Anyone else there? So did anyone answer my question about the situation in England, families living together, the different generations of people living together? Is that playing a role in England?
I can answer that question because I've not studied it, but you made a good point. In the UK, it's not usually the blacks, but usually the Asians who have like 3 generations living in the same household, and that's I guess that's one of the main reasons why things are spreading in certain areas. You get Liverpool, Birmingham, Manchester. It's probably much more concentrated than in London. So for right now, those areas are the ones that are of the highest interest, and that might be a cause. I don't know, but if you can extrapolate and from science, that's probably one of the most likely causes of how easily spread it is in those areas. Because if you have one person come into a household of 3 generations with COVID, then what happens? The whole household eventually gets it. So that could be one of the reasons too.
Yeah, so that's important, and thank you for mentioning that. And the reason why I mentioned that as well is because we really have a situation right now where we have studied that, and actually they are studying that right now in England, because since Friday until now, there's a lot of information coming out showing that the areas that he just mentioned, Liverpool, Birmingham, etc., that they believe it's household spread that's the biggest one. And we have found the same in California and in New York, that household spread amongst multi-generation is a big leader in the spread of it. And there's a big raucous right now in New York where the governor is pointing the finger at the Jewish community because they believe that their worship situation, and this is interesting, their worship situation and their family setup is the spreader of COVID right now in New York. And they are having demonstrations because they believe that they've been singled out because of their religion. And that's interesting because that's at this point in time something that's perceived to be a way of spreading the virus. And that's going to come down to what's going to happen in a couple of months' time when the Adventists decide to go back in church and get together again, because some of the members decide that we can't take this anymore. We got to get back to praising the Lord, and everybody goes to church, and then you get a big spread of virus. and then they look at the Adventists and say, the Adventists, look at them. What we have to be careful about, and I don't want to touch on anyone's toes, but nowhere in the Bible did it ever said that church is within 4 walls made of brick. I've never heard of that. I mean, Pastor, have you heard of that? Just in case I'm wrong on my theology, that never existed. If you look at church in the Old Testament, in the New Testament, you'll see that they went from house to house praising the Lord. They would have their small groups, and their churches would be within houses and homes in small gatherings. And so our longing to get back to church, I don't know if the Lord wants to teach us that it's the walls that have kept the message from spreading, and now he wants the walls down so that the message can spread. Any thoughts on that?
I think I have a question for Pastor.
Well, it's a good point, Elder, because Jesus was a kind of a revolutionist in the sense that when Jesus came on the scene, he was actually the first person to introduce corporate worship, in the sense that you had male, female, and also the disabled worshiping together, not in a building, but wherever it was, by the sea, in the mountains. Because you remember, even before Jesus came on the scene, that those with disabilities, they could not even enter the temple. So you had corporate worship wherever he went, but it was not so much worship in the sense of a place or a noun, but a verb. We've always, as theologians, we usually say worship is not the noun, it's not a place. It should really be a verb, something that you do and just about anywhere, from house to house, under a coconut tree, wherever.
Sorry, but did you not find with Christ, he was found in the temple on the Sabbath day, and he was reading from the book of Isaiah at the start of his ministry, and that was done in the temple setting. The reason why most of his teaching was done outside of the church was because the church was against him.
That's a good point. That's a good point. And you know, one of the things I like about your point there, he went over to the people who he knew that would ultimately reject him, because he wanted to make it known that he wanted to save them as well. But the majority that he knew would accept him were those not of the faith of that time. And so he said to them, not one stone will be left standing, because I'm going to knock down what you're glorifying, which is a building and a place. So, you know, that's one thing about our God that we have to really thank him for, that he went to his people and he kept going there and he kept preaching in the synagogue, as you rightly said. But he made sure when he sent them out, he didn't send them out. He sent them out specifically to small groups. And that's why you see, many of you may or may not know, but I am mostly in the last 25, 30 years being involved in the Hispanic ministry. And my wife's from Mexico, and that has taken me really into another world where when they baptize 6,000 people, not 6 people, not 60 people. And it's done by small group. We call it pequeños grupo, grupos pequeños, small group ministry, where an elder or a leader of the church or someone who has the desire to hold a Bible study in their home or on Zoom. And that's a question. How many of us have really contacted someone by Zoom and started a Bible study and added another person? We don't have to wait for the church to do that. Something we can do by ourselves. We don't have to even get paid for it. We can do it free. You can get a free Zoom account. But those small groups then have 5, 6 people. They never usually go above 10 people. And in the church of 150 people, each person has a small group. And so when they have a baptism, they're baptizing 400, 500, sometimes 6,000 people. And that's how growth is. And in a way, we're really going back to those days. Our church, for example, on Sabbath, on Sunday, we decided that we were going to, every elder had to have a Zoom account, and that we were to then have a WhatsApp account, and we were then to get 3 or 4 members and then add them to that. And so everybody had a group of members that they were to take care of, and ever so often have visual meetings plus have continual communication and prayer. So dividing the church in a way so we can really supply the basic needs of the people as we go through this very, very difficult period that we're in right now.
Doctor, there's a question here from Mary. I'm trying to read it. Do we need vitamin D tests as Black people, or all different complexions? Those fairer need more than those who are darker. Basically, I guess she's asking, do we as Black people need more vitamin D than those of fair complexion?
That's a good question. It's a very good question. What we do know is that the fairer your skin, no one knows if 1 + 2 + 3 +, we don't know about that. But we definitely know that the fairer your skin is, it's going to be harder for you the darker your skin, my apologies, it's going to be harder for you to activate vitamin D. Okay, so the darker your skin, the harder it is for you to activate vitamin D. We do know that in the US, I don't know about the figures in the UK, but we do know that at least 40% of pregnant women are vitamin D deficient. Women, okay, vitamin D deficient, and Black women, it's 70% of them. So, and it didn't in that study, it did not give the degree of Blackness, because I don't think there's an official tone scale as yet. I think the women probably have a tone scale for their, what do you call it, for their makeup. That's a very, very technical world out there, but generally speaking, it's not known to the degree of the darkness of your skin. However, yes, we should be checking ourselves yearly, and I think one of the things that we should do, and I don't think it is a standard in England, it's not a standard over here, but checking our vitamin D levels because of the amount of diabetes and hypertension and cancer we have, I think that it would be very beneficial if it's something that can be done to do, because you're going to find out that most of us have low vitamin D levels.
And another question in the chat was that you mentioned earlier that vitamin D supplements are probably not the most beneficial to us. So the question here was asking, should we take vitamin D supplements at all?
No, I wouldn't be that, thank you. I wouldn't be that drastic. My statement is more towards, and I'm just forgetting that I'm not living in England. In the US, we get lots of sunshine. And so, but over in the UK, how you get sun, how often? Like twice a year? For 3 weeks at a time, maybe, I think. Right?
Yeah.
Yeah, but most of you travel to the Caribbean anyway and have a good time for about 2 months. So so if you go to the beach a lot, you should be okay. But it's important. It's very important, because we live in the UK, we don't get a lot of sun exposure, and people, when the weather gets bad, we spend a lot of time inside. Am I right or wrong? We spend a lot of time inside.
Yeah.
Outside, and that's the reason why we need to be very careful. And the homes in England do not have large windows, windows from the floor to the roof. You don't have those kind of windows because the weather doesn't permit it, etc. And so you don't get a lot of sunlight or daylight exposure. So you want to check your level and start taking some vitamin D. I'm just saying that if you have the luxury of having vitamin D from the sun, go for that first.
Very good, very good. There's a question from Doreen Williams. You got to unmute your phone, please. There you go.
Can you hear me?
I can hear you now.
Yeah. Hi, Dr. Graham from America. Yeah. How are you?
Wait. Before you say anything, is this the Doreen Williams that I've known since I've been born?
You're blessed. Thank you. Concerning about the church, I thought, what I understand it to be that Jesus, his custom was to go to church on the Sabbath.
Yes.
And he went into a building. That's one. And then he said, because to Moses, he said, let them build me a sanctuary so I may dwell among them.
Yeah.
So now we want to go back to the church. I don't think we should thinking that, well, we shouldn't want to go back to there because that's what God says. He said it at and the church is us. The church is the people. We are not the building. We are the people.
That's right.
The building is just there for us to go and worship. And like you said, that was his custom.
Yeah.
So yeah, that was the point I was trying to make.
I think we're on the same page. Thank you so much. Nobody doesn't want to go to church to worship. But what we don't want to do is feel that we haven't worshipped because we're not in a building. That's what we don't want to do. Wherever we are, we need to praise God. And when we get the opportunity to be back together, we be back together. But never forget that there are those outside of the wall that needs to be reached.
Yeah. Okay.
And there's another question here, Dr. Graham. Are we to take K2 with the vitamin D? Please comment on why we need K2. I'm not totally sure what K2 is. You might know, but I'm not totally sure what K2 is.
Now, there's one thing I like to do is I like to be educated. So someone please educate me as to what is K2.
It was by Anderson Gray. I'm not sure.
Hi, it's Eleni Anderson Gray here. Yeah, I was watching one of the ministers from abroad, I don't remember, but it was at the beginning of the lockdown, and they were saying that you needed to take vitamin K2, vitamin D, because it buffers the vitamin D. So, but didn't explain exactly what the K2 does and what buffering vitamin D is exactly. Please comment.
Yeah, no, I just looked in Google. Okay. And it's basically menaquinone. And that's from the family of so no, you don't need that for your body to absorb it. Most of what we eat, generally, unless you're a totally malnourished person, most of what you eat will allow you to absorb very well the vitamin D that you get from the pharmacy or you get from the sun. It's not a necessity. There are people who have certain liver dysfunctions that may need types of vitamin K, but those are people who are fed special types of things through tubes in their stomach and things like that. But a normal person wouldn't need that.
Thank you. Thanks so much.
Sure. While we're on the topic of that, one of the things that I want our people to be very cognizant about is to never be very microscopic with our approach and singular in our approach to health. And I mentioned sleep. We're going to talk about exercise. We're going to look at state of mind, mental health. All these things affect our immune function. And the reason why I chose to open discussion, because I could have chosen many things to talk about, but what's real to us right now are these issues along with our chronic illnesses, because we can't forget that, because you go COVID crazy, we call it, and forget that people are dying of diabetes, you know? So we don't want to forget these things, but we want to be relevant. And that's why I wanted to discuss it today. We want to be relevant. And that's why I started out with a graph that showed specifically that 70% of deaths in the United States has been from African Americans when they're only 18% of the population. And then it's just like, for example, this morning, I saw something pop up that showed voting, a different topic, but just listen to this. If you're white in the US right now, you will probably average 1 to 2 hours in a waiting line to vote. But if you are black, you're going to average 4 to 7. That is interesting, right? Just by your color, you can tell how long you're going to be in the line. That goes back to what Dr. Graham was saying. There are lots of socioeconomic issues that compound our existence as people. So that's another component that we have to be looking at. And so someone made a comment in the chat regarding people who are working on the front line not having PPE, or them being the kind of workers, that's the kind of jobs that they had, etc. And yes, that's true. But why isn't that not the case for other areas? So why don't you get other races as well that's pronounced like this? I'm talking about like in the US. Why is that still 70% of the population dying? So let's say you get it. Why is it that you have the same people in the intensive care unit, but you have one dying more than the other? And I can give you some answers because there are things that have been studied. This is not new. This is exemplary, is amplifying the problem. We know that based on your race, if you're in a minority, you're going to be diagnosed later. You're going to be treated later. You're going to get certain studies later. This has been shown over and over. This is not new, okay? And it's not just to the US. This is a known thing. And there are certain biases that exist. And so we have to be aware of that. That when someone tells you, maybe you shouldn't take that, that surgery right now, wait another year or so and see. And if you had another person sitting in front of you who was a corporate bank supervisor or head of something, they'd probably say, what do you think next weekend should we do your surgery? So there are some real issues that we need to be aware of.
So we have about 5 to 10 more minutes.
I hope the person who asked about the vitamin D is very clear about the absorption. The darker your skin is, it's the harder for vitamin D to be absorbed. That's why you need to stay longer in the sun, or expose yourself more to the sun, or make sure you take your vitamin D level to make sure that you have adequate levels. If not, you need to then speak to your provider so that you can find out what levels of vitamin D need to be taken.
All right, I asked one more question. This question was posed to me some time ago. What do you think about the management of COVID not being conventional medicine, but being alternative medicine? We all grew up with Caribbean African parents and parentage and grandparents, and when we got ill, we never went to a hospital. Well, I never went to a hospital. The hospital was right there at home. And the backyard is some kind of bush or some kind of leaf or something that my grandparents would cook and boil, and worst tasting thing in the world. And they force you to drink it, and you cry. But the point is that you get better in a day or two. Okay. So what do you think about alternative ways of treating COVID in terms of, I know you're a conventional medicine, but things like ginger and calamine, I don't know, everything, all those different things that people use. Zinc, you talked about zinc earlier, but there's concoctions of this kind of seed, that kind of seed. What are your thoughts about that?
Yeah, well, for those who don't know, apart from being board certified in pediatric infectious disease, I'm also board certified as a lifestyle medicine physician, wherein we can literally take people with diabetes, hypertension, and get them to reverse their illness without using sometimes medicine. And so we are very much aware and promote lifestyle as a way to reverse, treat, and manage chronic diseases. And when it comes to infectious disease, let me just make a point regarding your comment, Dr. Graham. I want to be careful. I appreciate greatly. I've had the wonderful privilege of working in different parts of the world. One of the places where I worked for about 2 years was in Jamaica, in the West Indies, as a general practitioner. And now that I've had the opportunity of seeing things on a larger scale, epidemiological, looking at studies where we look at large populations, when you are in a very poor environment, where you don't have doctors, you may have just one doctor in the community, etc. You hear the wonderful stories of grandma giving you this concoction, etc. But if you look at the figures, the death rate amongst women in pregnancy is very high, disproportionate, and the death rate of newborn babies is extremely high. And the death rate amongst children in their first 5 years are way off the charts for those environments. So yes, we hear about these wonderful situations where grandma gives you this, but when you look at environments and you look at the figure of the death rate, not just morbidity, not just illness, but death rate of children under the age of 5, newborn babies and mothers in birth, that's why they call them developing countries, okay? So the reason why we have in the first world countries, we seem to have another baggage of diseases, which is more related to our lifestyle. So we get past the early 5 years, newborn and mother's death, but then we end up with lots of other problems. And the reason why we seem to do well with the first set is because you're pregnant, you usually go to the doctor as soon as you find out you're pregnant, you get checked multiple times, you get tests, you get monitored, etc., etc. And that drops the figures. I mean, you still have problems, but you drop the figures. The baby's born, you immediately have a doctor or a nurse or somebody check the baby, you know, and then the baby, and then the child who's up to 5, he gets checked every year, every month to see what's going on. So the level of illness is much decreased. Prevalence of disease is much less. And so I just want to mention that. Apart from that now, let's talk about what do we know about infectious diseases and complementary alternative medicine. That's a really powerful subject. Let me just say to you that most of the drugs that exist right now, look at penicillin. What do you think penicillin is? Do you think penicillin is something they make in the pharmacy, really? Penicillin is a fungus. It's natural. So let's not get carried away. Most of the antibiotics have their roots in natural products. I mean, if you want to get really serious about it, marijuana is a natural product. Cocaine is a natural product. Not because something is natural, it means that, oh, let's take natural products, okay? So there's lots of natural products out there, but we need to be very, very streamlined about what we're talking about. So, so far when it comes to COVID, there have been people and lots of good research so far looking at molecules that exist already. There's some really good computation modules where they're looking at millions of molecules that's out there, natural and not natural, and are looking to see which one of these molecules can fit into the area of the ACE2 receptor that allows the virus to go in the cell, and which molecule can fit and block the virus from coming in. And there have been a multitude of natural products and also man-made products that have been shown to actually block the virus. And there are quite a few of them. One of them that seems to do a good thing at doing it is vitamin. That's where the zinc came from, okay? They have some other products that's out there. There's some trees, especially it's a tree in China called the giant China something tree, but it has a seed, and that specific seed, the product that came from that seed has shown good promise in blocking the virus. Now the problem that comes, how do you then get these molecules into the human? Do they eat it? Do they get injected it? When it does go into soluble form, is it going to be lower potency? Does it then get to the molecule? What's the level of penetration you need to have before it gets to there? I mean, those are things. So there are substances that we're looking at that have shown promise in vitro, which means that when you look at them in lab studies, there's a whole bunch of them. I actually gave a talk about a month ago about 15 molecules that have been studied that have been shown to block the virus in the test tube, if you want to call it that. But no studies have been done in human because we don't know as yet. We're working on how to get that in a form to do that. Yeah, and as you know, that money is involved in everything, so there may be a component of that here. But how much vitamins do you need to kill a virus? I would never go to that degree of telling you to go, let's drink a whole bottle of whatever, and see if it will help you. We can't do that because we don't know. We don't even know as yet anything that can kill the virus. So we're way off when it comes to that.